my great honor to have the opportunity to be invited to speak here. And today I'm going to present the topic that I did during my research fellowship in Pittsburgh. And it's about the approach to the orbital surface of the greater wing of the sphenoid through the inferior orbital fissure. And this is just the anatomical analysis. And we want to do this study is because we see some tumors such as juvenile angiofibroma will grow from the pterygoparietal fossa and go through the inferior orbital fissures, even involve the sphenoid. And sometimes we want to know how much we can go through different approach to remove the tumor as much as possible. And I'm from Taiwan, and this is the anterior view of the skull, and we can see closer and look into the right orbit. So the inferior orbital fissure is the bony gap, which the boundary is greater wing of sphenoid posteriorly, and the zygomatic bone laterally, and the sphenoid bone medially, and anteriorly the orbital process of palatine bone and the maxilla. So according to previous literature, the inferior orbital fissure can be divided into three parts, including anterior lateral part, middle part, and the posterior medial part. And each part connect with the orbit and the other extracranial fossa. For example, the anterior lateral part connect the orbit with the temporal fossa, which means the area which contain temporalis muscle, and the middle part connect the orbit with infratemporal fossa, and the posterior medial part connect the orbit with pterygoparietal fossa. According to Professor Roten's article, they described that the boundary between the anterior lateral part and the middle part is the infratemporal crest. So it means the anterolateral part of the inferior orbital fissure is from the most anterior lateral aspect of the inferior orbital fissure to the infratemporal crest. And the boundary between the middle part and the posterior part of inferior orbital fissure is the pterygomesoid fissure. So it means the middle part is from the infratemporal crest to the pterygomesoid fissure, and the posterior medial part is from the pterygomesoid fissure to the mesoid strut. And this is from the craniotomy perspective. In the endoscope endonasal perspective, sometimes we cannot see the structure posteriorly when we go through the nose. So another article described that the boundary between the anterolateral part and the middle part of the inferior orbital fissure is the anterior border of the infraorbital groove, and the middle part and the posterior medial part is bounded by the posterior border of the infraorbital groove. So when we go into the nose and we remove the medial wall of the right mesoid sinus, we can see the view of the right mesoid sinus. And after we remove the mucosa, we can see the right mesoid sinus posterior wall and the bony structure around here. After we remove the posterior wall and the lateral wall of the right mesoid sinus, we can expose the periosteum of the pterygoparietal fossa. And after we remove the periosteum and the fat tissue at the pterygoparietal fossa, we can expose all the vascular structure from the right internal mesoid artery, and also the nerve structure from right mesoid nerve and the right infraorbital nerve. So here is the label here is the right inferior orbital fissure, and the pterygomesoid fissure is here. So according to the knowledge we just described, the posterior medial part of the inferior orbital fissure is from the mesoid strut to the pterygomesoid fissure, and it can connect the orbit with pterygoparietal fossa, and the middle part is from the anterior border to the posterior border of the infraorbital nerve. So it is equal to the width of the infraorbital nerve, and it can connect the orbit with infratemporal fossa. And the the anterior lateral part of the inferior orbital fissure is lateral to the infraorbital nerve, and it can connect the orbit with the temporal fossa. So in this study, we try to analyze the inferior orbital fissure and by EEA with medial mastectomy and the Cartwheel lock transmessery approach. By these two different approaches, we try to calculate and measure the length of inferior orbital fissure exposed and the area of the orbital surface of the greater wing of sphenoid that we can access. So first, we try to measure the length of the inferior orbital fissure. We use the navigation system and we dissect 5 cadaver specimen and measure the length from the mesoid strut to the most anterior part of the inferior orbital fissure, and we calculate it as the total length of the inferior orbital fissure. And then we measure the area of the orbital surface of the greater wing of the sphenoid. So we set 4 points. The first one is in the mesoid strut. The second one is in the most superior lateral part of the superior orbital fissure. And the superior lateral part of the area is related to the most superior lateral part of the greater wing of sphenoid. And then the most inferior lateral part, the point is related to the most anterior lateral point of the inferior orbital fissure. We set this 4 points and we calculate the area. So by EEA with medial mastectomy, we can dissect the inferior orbital fissure like this, and then we push the orbit upward to expose the greater wing of the sphenoid. Then we use a drill to drill the bone here, and then we can enter into the right middle cranial fossa. So we can calculate the length of the inferior orbital fissure that we can expose. And also we set the 4 points at the area that we drill, and then we can calculate the area that we can exposure. And then we do it, and then we do the Cartwheel locked transmessery approach, and we measure the length of inferior orbital fissure exposed and also the greater wing of sphenoid that we can expose. So we made a gingiva incision just above right canine, and then we do the subperiosteal dissection to expose the right canine fossa just below the right infraorbital foramen. Then we drill the anterior wall of the right mesoid sinus to get into the right mesoid sinus, and then we can remove the bone more and to expose more longer the inferior orbital fissure and also the more area of right greater wing of sphenoid. Then we can calculate the length of inferior orbital fissure that we can expose, and also we can drill more bone of the right orbital surface of the greater wing of sphenoid. Even we can expose the superior orbital fissure by this way, and then we can remove the bone here and to get upward to the lesser wing of sphenoid. Then we set the 4 points, and then we calculate the area that we can drill during this approach. So in our results, regarding the inferior orbital fissure, the total length is around 29.78 millimeter, and the each part length is listed here. And by EA with medial mastectomy, we can expose around 23 millimeter, and by Cartwheel lock transmessery approach, we can expose around 33 millimeter in total length. So we can see the length that we can expose is significantly longer by Cartwheel lock transmessery approach, and we can even expose longer than the total length of the inferior orbital fissure. It means we can go more lateral to the lateral limit of the inferior orbital fissure. And the EA with medial mastectomy, the length that we can expose is almost equal to the posterior medial part and the middle part, the length summation. So it means that by EA with medial mastectomy, we can expose just posterior medial part and the middle part of the inferior inferior orbital fissure. and this means the lens that we can expose by EA with medial mastectomy, we show it in red, and in the green line, it means the inferior orbital fissure that we can expose by cutaway lock transmersal approach. And regarding the greater width of sphenoid, we calculated the area that we can expose by these two different approaches. So it shows that by cutaway lock transmersal approach, the area that we can expose is significantly wider than EA with medial mastectomy. So it means that the red field is that we can drill by EA with medial mastectomy. And during our calculation, the height of the area that we can drill is usually less than 1 centimeter. And the green field means the area that we can drill by cutaway lock transmersal approach. So we can see the green field is is significantly wider than the red field. Regarding the difference between these two different approach, it's because the entrance and the trajectory are significantly different by these two approach. For EEA with medial mastectomy, if we try to go laterally, the trajectory will be obstructed by the piriform aperture. And if we want to go higher, the orbit will obstruct our trajectory and our instrument. By cutaway lock approach, the entrance is significantly lower than EA with medial mastectomy. So we can see if we want to go higher, the orbit compress will not so much compared with EA with medial mastectomy. So this picture shows that in the left one, this is the trajectory that we can get by EA with medial mastectomy, and the orbit will be compressed. And the right one means that we can go from the anterior transmedullary. So because the entrance is lower, so we can go higher compared with EA with medial mastectomy. So by this approach, the orbit will not be compressed so much. So in this picture, we can see that the red line means the inferior orbital fissure that we can expose by EA with medial mastectomy, and the red field means the area that we can drill, and the green line means the inferior orbital fissure that we can expose by cutaway lock transmersal approach, and the green field means the area that we can drill by cutaway lock transmersal approach. And this means if the tumor extends lateral to the infraorbital nerve, and the EA with medial mastectomy will not be enough, and the cutaway lock approach should be added. And if the tumor grows higher than 1 centimeter, higher than the inferior orbital fissure, then the EA with medial mastectomy is not enough, and the cutaway lock transmersal approach should be added. But for this area, the most superior and the lateral part of the greater width of sphenoid bone, the area will be restricted by the infraorbital nerve and the orbit. So if we want to remove the tumor here or the tumor involved here, the lateral orbitotomy should be added to remove the tumor. So this is our conclusion, and this is all my presentation today. Thank you very much.
Thank you, Dr. Shan, for this excellent presentation. Is there any question from panelists?
Thank you. This is only our anatomical analysis, so we will try to have some clinical cases in the future. Maybe we can add it into our presentation in the future. Thank you very much.